So I think we're going to go ahead and get started. If it gets too crowded up there, I think people can come down a little lower. The hierarchy of seating doesn't exist as much as it used to. First of all, I'd like to welcome everybody to the first grand rounds of the academic year. We actually jump-started our surgical grand rounds because of the importance of the topic. We had the schedule sort of start next week after Labor Day, like we traditionally do. And then, I mean, obviously what's been going on in the world with respect to gun violence was so important. I had a discussion with Peter, and we decided that we would do this. And so I know there's still some people on vacation, but I hope those who are logged in on Zoom, if you're not far, you're welcome to come down. There's plenty of seats in the front. The other thing I'd like to celebrate is the fact we're here together in the Bigelow for our first attempt at department-wide efforts to have grand rounds. I know we've had some in-person grand round speakers with a limited attendance, but everybody is certainly invited. And I know we've all gotten in the habit of doing this in our office and multitasking on our other screen. But again, I hope everyone realizes how important it is for people to get together. So we make the decision, COVID's over, we can do it in person. And our speaker, Dr. Masiakis, who's been on the front line of COVID care for 2.5 years or more, lets me know last week that he caught it. He took a vacation, did something with his family, and look what happens. So Peter's going to make some introductory comments, and then he'll pass the ball, or at least hand it off in football terms to his partner. So Peter needs no introduction, but I do want to talk a little bit about Peter and Hannah's efforts as the leaders of the MGH Center for Gun Violence. I think it was about 5 years ago, as things were looking like they're getting bad. I think they've gotten a much, much worse. Peter Slavin, as president of the MGH, realized the importance of sending the message that the MGH was dedicated to doing what we can to help in some ways for gun violence prevention. And Peter reminds me all the time, this is not about gun control. This is about gun violence prevention. And so we're going to try to keep all the politics out of it. But Dr. Slavin showed his wisdom by picking two really great people to lead this, Peter and Hannah Sachs. Hannah is a general internist in the Department of Medicine and as the co-director with Peter of this program that she helped found. She attended the University of Chicago School of Medicine and did her training in internal medicine, including a chief residency here at the MGH. She's joined the faculty, and her efforts have been really focused on health policy work and developing and implementing public health approach to addressing gun violence. She's done extraordinarily well academically, and has currently serves as one of the associate editors of the New England Journal of Medicine, and now has taken over as executive editor of New England Journal of Medicine Evidence. So it's just a spin-off journal of NEJM. So Peter's going to make some initial comments, and then again, the handoff to Hannah will take place. So Peter, I hope you're feeling well, and the mic's yours.
Thanks, Keith. Thanks, everybody. Not to make it light, but I think I'll be the first person on the wall of this amphitheater that's going to be able to speak. So good morning, everybody, and thank you, Keith, for the introduction and for the honor to open the grand rounds of our new academic year on such an important topic. Many of you know that I've been working in injury prevention space for many years, and it's sort of predicated on the fact that as a society, we often address healthcare problems after they occur. And that's sort of intrigued me for many years, when it's clearly preferable to prevent deaths and injuries and disease rather than to treat them. Prevention not only lessens the tolls on victims, families, and friends of victims, healthcare providers and health systems, but it also provides cost savings that could be applied to other pressing healthcare needs. In the last 15 years, I've been really lucky to be informing state, federal legislators on the importance of injury prevention, both at the level of lawmaking and about the importance to fund the work being done to identify prevention strategies. And that included firearm-related injuries. But it was 10 years ago in December, I was sitting on an interview panel with Carlos when the news about a shooting in an elementary school in Newtown, Connecticut began to emerge during our break. And if Carlos is listening, I'm sure that he remembers that moment. And like many others, I began to think about doing more to address gun violence in the wake of the Sandy Hook tragedy. 6 months later, I met Hannah for the first time in a small room outside of the medical ICU. And we started thinking about how we were going to work on this space, in this space. And I'm very happy where we have landed. So I'm thankful for being able to do this work with Hannah for the last 9 years, and now equally thrilled to have Cornelia Griggs join us to work on figuring out how to best mitigate this growing public health issue of gun violence in the United States. Although I would have loved to have been there with you today, COVID had other plans, as Keith said. So today, Hannah will present our vision and where we have gone with it. Here you go, Hannah, take it.
Thanks, Peter. We miss you. There you are. I thought he was going to be up there the whole time in the corner. I was really looking forward to that. Thanks so much for having me. Really honored to that this topic is a focus of Surgery of Grand Rounds, and beyond honored that as an internist, I'm standing up here in front of you. So I really do appreciate it. As we get started talking about this, I just want to acknowledge up front that every one of us in this room, Zoom or in person, brings our own experiences to this issue of violence, and discussions about violence and suicide and guns can be deeply personal for many of us. So I want to acknowledge that and just say up front that if anybody needs to step out at any point, I will not take it personally and really invite you to do that if that's useful for you. But we're really here, and as Dr. Lillimo mentioned, this is here as the very first kickoff grand rounds of the academic year. Because no matter who you are, no matter where you are in this country at this moment, it is really hard not to think about gun violence. This summer, in a span of just a couple weeks, we saw headlines like these: a gunman killing 10 people in Buffalo, in a church in Laguna Woods, the tragedy in Uvalde, and then 4 people, one of them Dr. Preston Phillips, known to many people, I think, in this room probably, killed in a Tulsa Medical Center. And that was just, all of those were just in a period of 19 days. And really the media stopped, as it sometimes does momentarily, briefly, too briefly it seems, during some of these tragedies. And they tell us the stories of the people who died. We learn their names, all of the names of those people who died during those 19 days in the center there. But if those 19 days, from May 24th to June 1st, if those 19 days were just an average 19 days in America, then a total of 2,348 people died from gun violence during that time. And we never hear their names. We never learn their stories. Just behind them in red here is just our attempt to put together some of what we know: the age, the state they were in. But really, every one of their stories, every one of their names, every one of their stories should be known. We have any chance of really understanding what gun violence in America really means. And when we add up those days across an entire year, the numbers are really staggering. It's about 45,000 people that are dying in this country every year from firearm-related violence. And when you put that up there with other forms of morbidity and mortality that are affecting our patients, it's right up there with some of the big ones. With pneumonia, higher than prostate cancer, way higher than melanoma. And I say that because when I was a resident, when I was in medical school and I was a resident, I don't think I'm alone in saying that I received not one specific lecture, conversation, education, didactic, anything about what it would really mean to bring violence prevention to the bedside. What trauma-informed care of patients who have suffered gun violence, firearm-related injuries, what that would look like. And contrast that with the number of talks I had on liver disease and thinking about the pathways, opportunities for prevention and intervention, how we treat them. And that just struck me, it struck Peter, it struck all of us together as we were looking at these data and learning about this together, as just both an absolute miss and a solvable problem. Gun violence right now is the leading cause of death among US children and adolescents, the leading cause of death among kids in this country, having overtaken motor vehicle crashes. And just to be clear and explicit about this, at every age group, this is an American problem. Right here, you see the US in blue compared to other non-US high-income countries around the world. At every age group, we're the only one where you can see a firearm-related mortality rate for kids 0 to 4 or 5 to 14. And at every age group, we absolutely just outweigh these other countries on this problem. So what do we do about it? The data are staggering, the disparities are real. What do we do about it? I think people often talk about this conversation as if it belongs in sort of one fight in DC over a law that will or won't pass. And really the mission of our center is recognizing that that is a really shallow approach to a complicated and multifaceted problem. That real change here comes from community-led approaches. And what do we mean by that? First, if we're going to talk about gun violence, we need to understand what we mean when we say gun violence. It's often talked about in the media as if it's one thing, but it's really important to recognize that firearm-related deaths are due to different types of violence. There are these mass shootings, like the ones that ripped those headlines that I shared earlier. Homicides and other interpersonal violence that disproportionately affects communities of color right here in Boston and around the country. These accidental or unintentional shootings where a 5-year-old finds an unlocked and loaded gun and shoots a sibling or a neighbor. Police-involved shootings. And suicide, which we don't really talk much about and often is left out of this conversation. But when we look at the data, these are the numbers. These mass shootings that dominate the national discourse account for less than 1% of all gun-related deaths. Unintentional injuries, about 2%. Those police-involved shootings, 1%. Homicides, 40%. And suicide, the least discussed form of firearm-related violence, accounts for the majority of gun deaths in this country. And when we start to think about it in that way, how do we think about these different types of violence? Easy access to guns is absolutely a common link, but each of these types of violence has different root causes and opportunities for intervention. And all of a sudden, that framework gives us an opportunity to dig into each of these different issues and think about how we might approach it. So first, we're our own community in some ways. What's our role as a medical community in this national conversation? First, we have to talk about it, and we have to talk about this as a medical issue because suicide rates are rising across the country. And the majority of all suicides are due to firearms. We see this is more common in men than women, but the rates are rising across the country, and that's true in every state. It's not a problem in one part of the country or another, it's true everywhere. With again, the majority of these deaths being due to guns. I'm going to be very honest throughout our conversation this morning about when and why there aren't great data for some parts of this conversation. I'll be very transparent about that. But something you can absolutely take to the bank is this. Access to firearms is an independent risk factor for death from suicide. It's been shown time and time again in really well done studies. This is a meta-analysis published in Annals of Internal Medicine a few years ago, looking at a series of studies and showing there's a 3-fold increased odds of death from suicide if somebody has access to a firearm compared with that same person, the same set of circumstances, those same stressors, but who doesn't have access to a gun. Now, in some ways, how can that be? I think we've all probably heard the line, something along the lines of, if somebody really wanted to do this, they'd quote, find another way. But really, the data show us that that's not true. And these numbers give us a sense why. Pills, overdoses are by far the most common method of suicide attempt in the United States. By far. The case fatality rate if somebody attempts suicide with an overdose is 2%. Contrast that with firearms, where the case fatality rate is 90%. We get used to this on the medicine service for sure. We admit a lot of patients. I'm an inpatient attending. I came off service literally a day ago. We admit a lot of patients that are in extremis, struggling with something acute happens. They're intoxicated, other substances in their system, and they come in either after a suicide attempt or with suicidal ideation, and they get admitted to us and on the medicine services for treatment of withdrawal and medical stabilization. And so often, by the time our psychiatry colleagues, who are phenomenal, come by a day later, when some of the substances are out of their system, these patients actually don't often meet inpatient level of care. We're often discharging these patients home, hopefully with increased resources and better connected. But really, that moment of suicidality, that moment of suicidal ideation that leads to an attempt is often much more fleeting than I think we've understood previously. But for people who attempt suicide with a firearm, we never get to meet them. They never get that second chance. I think it's really important to know that more than 90% of people who survive a serious suicide attempt do not go on to die from suicide. More than 90%. So this is not about postponing the inevitable. If we can change somebody's access to lethal means in their moment of crisis, we can save their life. Which is a pretty transformative opportunity to think about how we can do better for these patients in those moments. The rate of death from suicide increases among older adults, specifically among older adult men, and this is really all driven by guns. I do a lot of work in suicide prevention in older adults, and I really started that work because I was sitting there with one of my RAs putting together some of these data, and it was just striking to me that if you look on the far left of this graph, you see all age groups, men in blue, women in green, firearm and non-firearm suicide. And for all age groups up to age 64, it's pretty even if somebody attempts suicide, if somebody dies from suicide, what those methods were. Then look at the older adults, every single age group as people get older. These are all driven by firearm suicide. And if we think that part of the measure of a society is how we care for the most vulnerable among us, including our older adults, really these data say we have a real problem. And we're really just starting to unpack. Our center's doing a lot of work thinking about what are those multifactorial causes that are leading to this in older adults. Is this about cognitive impairment and dementia? Increasingly, we think that's part of it. Is this about social isolation? Is this other stressors? Is this pain? Is this medical comorbidity? So much work to be done here. But what's really clear is that doctors seeing older adults, which is all of us in different settings, are not talking to older adults about guns. Younger adults who die from suicide, often it's a new acquisition of a firearm. For older adults, we think we're launching a study in the field in the next month to look at this. We think for older adults, these are guns that have been in the home for decades. They've been sitting around, and nobody ever thought, as people were getting either more frail or sicker or developing cognitive impairment, the same way we talk about the keys and car safety and other things like that about home safety, we haven't been talking about guns. The VA is a leader in this space in many ways, and the VA is one of the only organizations that explicitly encourages conversations about firearm safety when a diagnosis of dementia is made. But thinking about that as just a holistic part of the home safety conversation is really an important and really under-recognized among clinicians. And maybe even without this conversation, we're all like pretty good at it. We know to do this. We know to talk about guns. It won't surprise you that when we looked at our own data right here, we found that we were not so great at this. So this was some work led by a pediatric resident a couple of years ago who looked at RED, looking at all kids and adolescents who are coming into our emergency department with active suicidal or homicidal ideation. So identified as potentially high risk in every way we as a medical system know how. And our question was simple, was how often do pediatric residents, when they see these patients, how often does anybody ask about access to guns and document that in the medical record? And what we saw over the course of a year in 98 consecutive cases, it was 5 times. Was there any documentation about guns in the medical record? 5 times. In about 2/3 of cases, somebody documented this before discharge. Usually it was our psychiatry colleagues. But that meant in a full quarter of cases, where young people were coming in with active suicidal or homicidal ideation, nobody asked about access to lethal means, access to firearms at home. For me as an internist, that's like somebody comes in with an MI and we forgot to ask them if they smoke. I mean, it's the #1 most modifiable risk factor for death for what we know that this person is struggling with. And we have to figure out how to do better. And it's not surprising. We brought together focus groups. We talked to people across departments. And first of all, to make very clear, this isn't just pediatrics. Here's some prelim data from our group using natural language processing to say how we doing, all of us. Us in medicine's on the far left, surgery here is on the far right. We used alcohol and tobacco as positive controls. We looked at 80,000 consecutive hospitalizations and said, how often are we talking about these things with our patients? So for alcohol, you can see that in gray. In about 60-70% of admissions, we're talking to patients about alcohol in some way and documenting it. Smoking, it's about 60% in orange there. And that blue line, if you can see it, for medicine and surgery, for our services, it's hard to see. It's far less than 0.5% of times were we asking any questions throughout the hospitalization. And when we think about all the questions that are on, for example, the nursing intake screening when hospital admissions, we're asking if rugs are tacked down, we're asking about if people have falls, all of these questions that we ask about so regularly. Probably a pretty big miss when we're thinking about this. So when we talked to people, we brought together focus groups. It wasn't rocket science, right? People weren't asking about their patients about guns because they'd never been taught to talk to their patients about guns. For any resident in the room, I can demystify all of medicine in like 2 seconds. We're good at anything we're trained to do, and we have no idea how to do anything we're not trained to do. It's really, it's true in medicine. I'm going to bet that might resonate in surgery as well. And we weren't talking to people. We weren't sharing with students, with residents, how to have these conversations. So it's no surprise that none of us were doing it routinely. The other thing is that people were most afraid when we were talking about these conversations. They were most afraid first of the political nature potentially of this conversation. And then second, they had no idea what to do. If they were able to ask and they asked thoughtfully and asked if there was a gun at home and somebody said yes, they're paralyzed. They had no idea what to do next. And again, as Peter and I were approaching this, we get, these are solvable problems. Like we can design a curriculum to get at that. There's a couple of different frameworks. When you're talking to patients about guns, again, I promised you when I would share when there are great data, this isn't a perfectly validated tool, but it's a framework of maybe the questions you might want to run through and think about. Like anything else, when you're talking to patients about guns, incorporate it into what you're doing in a non-judgmental, medically focused way. Got to workshop your own language. I'd invite everybody to think back to when they first took a sexual history and had to learn their own language and stumble through that, and now can do that really thoughtfully, This is the same way. It may feel awkward if you've never done it before, but as you become more comfortable with it over time, it just becomes part of the history that you take for any patient. One way of introducing it is because there are risks to having a gun in the home. I ask all my patients about gun access and safe storage. So if you ask a patient if they have a firearm at home and they say yes, one framework is to ask then follow-up questions about the 5 Ls. So is the gun locked? Is it loaded? Are little kids at home? Anyone at home feeling low? Again, getting at that risk between suicide and firearms. And then that last L, maybe a little bit of a stretch. Everyone at home learned about gun safety, but can we give people resources about how to make that firearm safer? Away for photos. One of the other things that is really important always is to understand sort of the medical legal landscape of where you're practicing. Every state is different, and in Massachusetts here in 2018, Massachusetts became the 14th state to pass a so-called red flag law, an extreme risk protection order law. How many people have heard of these laws? Got it. We see one person. He didn't have COVID at the time, but he's right there in the corner when Governor Baker was signing this bill into law. If you ever have a chance to go to Beacon Hill with Dr. Masiakos, I just suggest that you take it. He's so well known and so well respected on the Hill, and when he talks, it's not about politicized advocacy. It's about here's what the evidence says, and here's how I think we can have better policy and better data collection and better infrastructure. And he just has this way of sort of bringing down the temperature around any issue. And this one, his advocacy for is no exception. These laws have quite good evidence in their efficacy in suicide prevention, and in 2018 signed into law here in Massachusetts. So extreme risk protection orders allow for a civil pathway. These are not criminal, a civil pathway to remove firearms from the home of somebody you think might be at risk to themselves or others. Every state has a different flavor of these laws. In Massachusetts, clinicians are not among those that can personally file these. So I see our role as educational, sharing with family members who might be worried about somebody else at home that these exist. MassERPO, MAERPO.org is a great site that is designed to be very user-friendly and walk people through. Our social workers here are are knowledgeable about this. So in residency, as in life, never worry alone. If this comes up and you think it might be useful, there are a lot of people around here, social work, Peter, me, many among them, who would be happy to help and talk you through any things that come up with that. If you're just talking about how do we remove this conversation from sort of the politicized nature to really what it is about caring for people at the bedside. There's about 4.6 million kids in this country that are living in homes with unlocked and loaded guns. 4.6 million. Whatever your politics, we all think that number should be 0. And when we think about that, there's some concrete things that maybe we can do. On our intranet right now, PCOI, I don't know how much you use that, but we can happy to talk more. On our intranet, we have a lot of resources available for patients. This sheet among them talking about different safe storage options. Across internal medicine, we put free gun locks in most of our clinics. Happy to do that in surgical clinics if that'd be useful. Just let me know. We'd be happy to come talk through that. But we have these cable locks that are freely available. They sit next to our bike helmets and our condoms and all the other harm reduction tools that we use all the time. They're cheap. They're not the best. They're much better than nothing. As you go down this list, you get sort of the much more expensive and more effective storage methods. But these cable locks are absolutely better than nothing. And I think they've done a couple of things as we put them in our clinics over the last few years. One is all of us as doctors we're people. We're much better at having conversations when we have like swag or stuff to hand out. We're just better at it. It's a nice visual reminder. It's also a really nice concrete answer to diffuse any concerns that come up. If a patient says, "Why are you asking me these questions?" It's because I have a free gun lock here if that's something that's useful to you. It's a really concrete answer of something that we're offering or we're happy to do and share if that's useful to patients. Originally, I'm a investigator at heart. I'm a researcher, and we had a lot of stuff in place to think about how we were going to track the utility of these over time and who was still using them at 6 months. And it really is the importance of involving patients and community in all the work that we do really at the center. And people told us very early that not one person would take a gun lock if they thought we were going to track who's taking them and call them later. And so honestly, we gave up a little bit on exactly some of the evaluative component of that and decided to make them broadly freely available. And watch them disappear off our shelves, which they do quite regularly. And honestly, right now, that's good enough for us. So how do we do this? How do we train people? How do we get people to understand all this stuff that's not rocket science? This is all learnable. So we started and we designed a curriculum. We brought residents and attendings across every department, across 6 departments in this hospital, all together in a room. And let me tell you, as an internist sitting back watching you guys in surgery and our psychiatrists all in a room bantering about this, it's just the best. So anything that you can do to make things more multidisciplinary as you're creating stuff, I would just strongly recommend it. But we created a novel case-based simulation program. We used authentic cases based off of what our residents and attendings here were saying that they were seeing. We hired a whole crew of standardized patients to come in and act out these cases. And we gave every incoming intern in our hospital a chance to just practice these cases. And in our first year, we trained 150 residents. And then the next year and the next year, we've been doing this since 2019. A lot of this work has been resident-led. Dr. Chuck Rickert, a recent grad of this program, took the lead on a lot of this work. And this paper was published recently in Academic Medicine, really showing what we know. What our hunch was, what we know is that if we teach people to have these conversations, they get much more comfortable with these conversations. If we share with people where these resources are and how to engage them, they go from not knowing about the existence of any of them to feeling pretty good about how to use those resources. And of our residents coming in across departments, medicine, surgery, pediatrics, emergency medicine, OB, psychiatry, across all of those departments, it was about 70% of our incoming interns who had never before in their training had any education about gun violence prevention or firearm related violence, 70%. And those that did had sort of one lecture was the usual. So we do this continually. We're at programs all across the city. I just came back from Austin where we're implementing this program at Dell Medical School, in the PA program at BU. So this education program has been fascinating and interesting and is spreading. And one of the barriers to spreading it is, of course, it's expensive to hire standardized patient actors and go through all of this. And so Dr. Cornelia Griggs and Dr. Masiakos have been taking the lead on this work, the two of them together received a grant and are working with a group at Cincinnati Children's Hospital and are turning our whole entire in-person educational training into this very cool, very fun avatar-based training program. So you can go through this whole thing from your computer and they get programmed with different answers, and it is very fun and much more lifelike than I would have possibly believed. So much work that's being done here is yes about gun violence prevention, but is also really morphed into a lot about educational methods and how we scale these types of interventions. So it's just some of the things that I think are important to recognize about some of our concrete roles here as clinicians. But you can't do this work in any way without really being grounded in the community where you're practicing. And so what's the experience of gun violence here in Boston? one of the safest cities and one of the safest states when it comes to gun violence. What's the experience of people here? And what do I mean when I say that we're one of the safest states? I mean, literally, by the data that we have, that we talk about, which is gun deaths in this country, Massachusetts has the second lowest rate of death from gun violence in the US. Second lowest rate of death. Hawaii beats us out by just like a little bit. Compare that with some of these other states, and we're a little bit smug about this. So many times you hear so many conversations of if every state did what Massachusetts did, passed the laws we passed, we would save tens of thousands of lives a year. Massachusetts is the best. Boston is great. The number of times you hear that sort of narrative, you hear that a lot. And yet when Peter and I started doing much more work in communities that are most affected, meeting people right here who've been on the front lines of this type of work for decades in our city, that is not the story we were hearing. We were hearing stories of young people all across our city who told us that they dodge bullets for a living. We were hearing stories of young people who were taking the long way home from school because they didn't want to walk by that car that had been there riddled with bullets. People who were waking up from sleep at night that the sound of a gunshot in their neighborhood was normal. And how can that be? How can that be if we know these data? It's a few dozen deaths in Boston a year related to gun violence. How can you ask more of a big city? And really, we started to recognize that, wow, deaths are the wrong metric if we really want to understand the impact of gun violence for people living in our city. Gun deaths are really just the tip of the iceberg. We think about non-fatal firearm-related injuries, people who are shot and survive. Those are people that you all take direct care of. Those are people that become our lifelong patients. And yet we don't know nearly enough about them. Guns don't have to hit anybody. Bullets don't have to hit anybody to cause trauma. If we think about the impact on neighborhoods or the sounds of gunshots and the noise of gunshots and the whole attendant emergency response that follows one of those shots. If that's a normal part of 2 a.m. in your community, there are a lot of impacts there, even if that bullet doesn't strike a person that night. Guns can be used to threaten people but without even being fired. And then all of that at the foundation is really the community and individual fear and experience that is really the foundation of what it means to really understand the impact of this problem. And what's very clear is those data that I showed you and really news headlines, the way this story is covered in the media, this topic is covered in the media, news headlines are really failing to capture the depth and nuance of these stories. And what do I mean by that? We have to start with data. That's what we do. That's how we understand what we're doing and whether or not what we're trying to do and implementing has a chance of working. I told you that in 2020, there were 45,222 deaths from gun violence. I know that number precisely. That is well tracked. And in contrast to that precise tracking of fatalities, data on non-fatal firearm-related injuries are limited. I was giving a talk on this a few years ago, and these are data from 2018 or 2017. You go on the CDC website, it looks all official the way it does for deaths. It looks like the same program. You can pull it up and see how many non-fatal firearm-related injuries there are. And you see that number there, 133,895. It sounds nice and precise. That number, to be clear, appears in a bunch of medical literature in the lay press. These data were being used regularly. And maybe you notice the two asterisks sitting there indicating that it's an unstable estimate. Here's the confidence interval. So it's okay to chuckle at surgery grand rounds. We do it in medicine all the time. There's the confidence interval. The best data that our government has to share on this problem is somewhere between 30,000 and 230,000 non-fatal firearm-related injuries. I mean, that number is so imprecise as to be entirely useless when we think about how we approach this problem. And that's a policy choice. The data infrastructure could be there if we invest in it. And to CDC's, I'll say credit. They now suppress these data, recognizing that bad data are worse than no data. And now this is from last week. If you try to go look at it right now, they suppress these data and say we don't have good enough estimates to do this. Again, this struck us in our group as we're sitting around in our own lab meetings as really solvable problems. How do we use claims data? How do we use hospital EHR data? How do we use things to make better estimates of non-fatal firearm-related injuries? And the Department of Surgery here has so much expertise in this space thinking about this. So I knocked on David Chang's door at part of the Codman Center and said, help me think through. Let's talk about how we can track non-fatal firearm-related injuries. We need to be able to understand that. So we started in New York. A postdoc in his group led this effort. looking at New York over 11 years. And from this paper, I think there are really two takeaways from this publication. The first is, of course, this is trackable. Of course, if we invest in this infrastructure and we invest in this, we can track these. And second, what is so clear from this is that the burden of these injuries is not distributed equally in this country. That Black Americans are disproportionately affected by this violence, and we have to recognize the implications of that and do better. So we're talking about non-fatal firearm-related injuries and trying to track that. Now, what's the impact of the gunshots going off, and how do you think about tracking that? I don't know if anybody here has heard of ShotSpotter. Is that anything anybody's heard of? If you walk through Boston, and not everywhere in Boston, but a lot of Boston, and you look up on lampposts, you'll see little microphones. They're actually not that little. You see microphones. Cities across the country are mic'd up in this way and detect a gunshot. A gunshot goes off. If 3 different microphones pick it up and triangulate it, it goes to the headquarters in Northern California. Within seconds, EMS is activated if the individual, it's human, sitting there thinks it was a gunshot, and activates EMS to that spot. So just to think of some of the casual trauma around some of these things, if that's even a phrase, as people were setting up the ShotSpotter in Cambridge recently, they're like firing gunshots off, trying to like test it. Just thinking about the trauma that's perpetuating in neighborhoods. But now, if you walk and go see lampposts, you will you'll notice these in a way that you maybe haven't before. But what are the implications of that, and what do we know if we start to look at the number of shots that are fired in our city? What we see, just looking at 2018 to 2021, 40 years of data, that gunshots are fired almost every day in our city. The darker purple, if you see a totally white box there, a gray box there, no shots are fired. White is 1 shot fired, and purple is the more and more shots fired every day. Each of these little boxes represents a day in this city. If you're looking at 2021, it's hard to find empty boxes. This is the experience of people in our city. Gunshots going off every day, multiple gunshots going off on many days right here in our city. And a lot of this group, a collaboration with our center and others in a group here that's focused on sleep medicine. It's been one of the most fun, interesting parts of the work that Peter and I do, are the collaborations that we formed with different methods experts and different content experts, and the ways that this issue intersects with so many others. And why sleep, people? Because these gunshots happen at night. If you look here, you can see in the middle here is daytime, and sort of at either ends are those overnight hours. These gunshots are occurring most often at night, and that's not surprising to people. But what does it mean? What are the implications if you're living in communities where these gunshots are going off all the time? And it's not just the gunshot, let's be clear. It's the gunshot, and then in Boston, it's EMS, it's fire, it's police, all of that response that shows up in your community on your street at 3 in the morning. What are the implications for sleep of that? And I want to be very explicit about it. The burden of this trauma is not distributed equally in our city. So here's part of the map showing that areas including Dorchester, Roxbury, Mattapan are affected by this at higher rates than others in the city. And it lets certain policymakers and certain doctors, everybody think that maybe this isn't as much of a problem as it is. And that's because we're not elevating the voices and the stories of people who have been on the front lines of this issue for decades, who have been struggling with this and trying to improve this problem in our communities. Really, one of the missions, one of the things we have to recognize, Peter and I can form a Center for Gun Violence Prevention at a place like Mass General. We get to be on the front page of the Boston Globe. Resources flow in. We have grant mechanisms. We can start to do that work. And yet people who have been doing this work for decades struggle to get not only that recognition, but that platform to talk about their stories and their visions for their communities. And what would that look like? What would happen if we center the voices of people who are most affected? It's a simple question, but probably the one that is way too often not asked, and it's the most critical question that has to be at the foundation of this work. And we've had partners and community organizations that have absolutely have taught us infinitely more than the other way around about what we can do to support, to elevate their voices, to support them, to be partners in this work together, to make sure that the work that we're doing is working towards endpoints that the communities that are most effective find valuable and important. But we really need to figure out how we change this national narrative. Peter and I are very good. We're sometimes pretty arrogant. We think we can like pull off a lot of stuff, but we're pretty good at recognizing when we're at our limit. And what we're hearing from communities is that we needed to transform media narratives. We needed to develop all different types of media. We needed games, we needed videos, we needed PSAs, we needed all these things to change the narrative. And I don't know how well you know Peter, but if you know me, like that is not in our skill set. We're not like art, I'm not an artsy type, like that's really not what we do. But we're pretty good at looking around and saying who's much better at this than we are and who can help us. So Peter and I, like at 1 p.m., I don't think either of us had seen like the light of day in many months, and walked across to Emerson College. And we met with one of the deans over at Emerson College. And honestly, our vision was pretty small that day. We were looking to create a few videos to help talk about how we counsel patients about guns. We wanted to talk about these issues. And one of the deans said, well, why don't we just have a course? And we can create your videos for you with your input, and we'll have students do this with faculty. And what we created, we started to bring in community partners, and we created a narrative called Transforming Narratives of Gun Violence, which right now at Emerson College, every single semester, there are 2 to 3 courses that are happening with survivors from the community as teachers in these courses, really taking these classes side by side with Emerson students, people from our center, Emerson faculty, all with the specific question of how do we transform narratives of gun violence? If this video will work, I want to show you just a quick intro about this work.
That's not our Boston.
That's not our Boston. That's still not my Boston.
It's the Nowhereville Boston.
That's not my Boston. It's about this community. That's not my Boston. The children don't deserve to be hit. They don't deserve to be shot down.
For every person shot by a firearm, at least 10 immediate family members are impacted. Repeated gun violence in the systems that perpetuate it lead to trauma for individuals, families, and entire communities.
Child dies in the emergency room from a gun wound and nothing happens.
Coming into the hospital and somebody making a cold remark like, well, which one are you here for? Because there were multiple people who were shot that night.
To make that John Doe or unknown male a person, right?
How is it that journalists are covering these stories and are choosing these sensationalist headlines instead of in-depth reporting? How is it that policymakers are making decisions about how to allocate funding without really understanding the voices and the stories of the communities whose policies are affected directly by them?
We are a community
Of storytellers.
Listen up the voices
of those most impacted by
Gun violence in our city.
Every day in Boston, neighbors are coming together to support one another.
When individuals like me, who were formerly incarcerated, we do commit to the uphill journey of building a new life and paving new pathways for those who will come after.
Transforming Narratives of Gun Violence is a collaboration between the Engagement Lab at Emerson College, the Center for Gun Violence Prevention at Mass General Hospital, and the Louis D. Brown Peace Institute. Through co-created documentary, interactive and immersive media, games, journalism, theater, and more, we are inspiring solutions and interrupting cycles of violence by focusing on what people have, not what they lack.
Social Impact Studios are semester-long experiences at Emerson, where students and faculty work alongside community members to understand the roots and impact of gun violence narratives in the media, so that they can create new ones.
The initiative is guided by a collaborative leadership team, including members of community organizations, doctors, elected officials, faculty, and students. The leadership team guides, amplifies, and distributes the narratives we make together.
To healing, to peace, to sustainability. What are we transforming to a better community?
So just share that of, there's some projects that you start, you know exactly where you're headed. Like you could design the shell tables before you even get started and you just need the numbers to fill in. This experience has been totally different than that. This has been about how do we bring what we think are the right people to the table together with the right resources and see what gets created. Last semester, there was a documentary film course, and together they created, so side by side, survivors, mothers who lost their kids, whose kids were murdered by guns in this city, took this class side by side with Emerson students, faculty, people from our center. And together they created a documentary, a 20-minute documentary called Quiet Rooms, that was based on a perspective in the New England Journal by Peter and Cornelia that they wrote together about the room that you all have been in way too many times, where you tell mothers that their kid died. And this documentary says what happens next. What's the experience of people in that room? And then what is their experience? What happens next? What do we need to know? What do they think we need to know as doctors about how to do better in that moment? And what do they think we need to know about how to better support communities and people who are experiencing that trauma? And if you have that 19 minutes, transformnarratives.org, the media from every one of these classes is freely posted. I would just encourage you to watch it. I've now seen this many, many times, and every time I learn so much that's new. And the Louis E. Brown Peace Institute is a Dorchester-based organization that has been working on this issue for decades, supporting families who've been impacted by murder in this city. And one of the things we recognized is that one of the most important things that we can do is just show up. There's a Mother's Day Walk for Peace that happens every single year in this city. And this year was back in person, thankfully, because it's just an incredible morning. And 5 years ago, when we were meeting with the CEO of the Peace Institute, Clementina Cherry, whose son had been murdered in this city, we asked her, "Why didn't you ever come to Mass General? Why didn't you ever ask us if we would be a sponsor of this?" And her answer was as direct as profound as she said, "It never occurred to me Mass General would be interested in something like this." And that's really all we needed to hear to be activated. Mother's Day was like a week later. We got a ragtag team together. And every year we've started earlier and been more organized. And I would never bet against Peter when it comes to fundraising, I think, because I would bet every attending in this room donated this year, thanks to his persistence. But now we went from that a couple of years ago, that answer, to now for the third straight year in a row, MGH is the biggest supporter of this walk, of this community organization in our city. And that's just, honestly, if you ask Peter and me what we're proudest of and what we want to keep working towards, it's not the number of papers, even though we're glad that we're being productive in that space, but it's being in community and showing up and really learning and being supportive in ways that we think have impact. I want to bring us back as we near the end of our conversation to where we started, talking about about these mass shootings, because they're a small fraction of the problem, but they dominate the national discourse. And when they do that, they also dominate what the solutions that people are throwing out, the suggestions that they have to offer that can be misguided. So I just want to talk directly about a couple of the proposals and things that are out there right now. Hardening schools, hardening has come up all the time. Right, so let's talk actually about the implications of what it would mean to harden schools. There's 130,000 secondary and elementary schools in this country. So if you would need 5 armed guards per school, which is a really conservative estimate based on what people think you would need, which is multiple for the perimeter and then somebody on every floor, you would need 650,000 people, a force of 650,000 people across the country. Just to put that in context, the US Army has 481,000 active duty personnel. So not even accounting for colleges and movie theaters and concerts and places of worship and bars and so many other places where we've seen these tragedies unfold across the country, not even accounting for those, we would need a force bigger than the US Army. And we need to be honest about that. You can propose that as a solution if you want. We have to be honest about calling for the greatest militarization of the civilian population in American history and the predictable negative consequences that are going to come from that, and what it means to try to turn schools into lockdown police mode. Another solution that's often been thrown out there that I just think is worth addressing is that tourniquet training programs, I think, are unlikely to make a dent in this problem. To the extent a few years ago in 2018 that there was any federal funding for this issue, it was a couple $1 million that was allocated for these Stop the Bleed programs that the American College of Surgeons has been a real leader of. And again, we just wanted to be grounded in the data. We asked a very, again, simple question. We needed partners that knew these data sets better than we did. So we went again to David Chang, to Numa Perez, who helped lead some of this work, along with another postdoc. And we said, what percentage of these injuries are even tourniquetable? That's a word, we made it up, so it is. But we're talking about these isolated vascular extremity wounds. Like, is that what people are really dying from here? And what we what we showed, what we saw, is that it's about 2% of all of these types of injuries that are tourniquetable. Again, I am not trying to brand myself as the anti-tourniquet person. They probably have their place in certain ways, but really important to recognize that if we're going to suggest a policy and put resources which are limited into certain things, we really do have an obligation to understand the potential maximal impact that a policy like that could have. And I think being grounded in data, in numbers is particularly important. Another thing that I think we need to be also more conscious of and really more thoughtful about than we have been is active shooter drills. It's now more than 95% of all public schools across the country do some sort of active shooter training. 95%. If you think about any intervention, we would try to get all public schools across the country to uptake, but this is the one we picked, says a lot. We have no evidence that if hell comes to school on a given day, that this type of training is particularly helpful. There's growing anecdotes, and our center is focused on really generating data to understand what the experience of people, especially young people who are going through this day in and day out, are experiencing. What is the cost of potentially turning all young people in this country into mass casualty responders? School, we know, is by far still the safest place for kids in this country. And scaring people, convincing people to not come when, and the schools that do announce these the day before, their absence rates go up. What are the implications of what we're doing there? And I think that's just really important that we try to understand. This December marks 10 years, unbelievably. 10 years since my cousin Mark's 7-year-old son, Daniel, was murdered at Sandy Hook Elementary School. 10 years seems hard to believe, except his older sibs in the corner there, one graduated from college and the other's in college, so it really has been. And shortly after that, there was a porous background check bill, if people remember back then, that got introduced in Congress, and people sort of expected it to pass, and it got voted down. It failed. It didn't pass the filibuster. And my cousin Mark here introduced President Obama in the Rose Garden that day. And one of the things I hear so often, really flippantly, is people say, if Sandy Hook didn't change things, nothing will. And I just want you to hear from me that in the aftermath of that, the worst things that in the aftermath of that, we talked about it as a family, and we recognized that change doesn't happen instantaneously. It does if the only problem was just a lack of awareness. But when real structures and real resources are propping up or maintaining the status quo, and that's what's going on, then real change doesn't happen instantaneously. It takes resources, it takes strategy, it takes data, it takes a thoughtful approach, it takes a movement to really think about how to dismantle some of those structures and build a new vision. And we said then that was going to take 5 to 10 years to even be able to get off the ground. And I just want to bring that up because in the wake of these tragedies, whether it's one of the ones we talked about in the beginning, or I fear one of the next, you're going to hear in the aftermath, or you'll hear in the aftermath that something needs to change. And then way too often, way too quickly, it's replaced with this learned helplessness that nothing's ever going to change. And I just want to share that I think that things change because we have to make things change. And in that space, that's what our center, the work that Peter and I do together, has been really dedicated to doing. And I could not be more grateful to work with the most incredible partner in Peter, but all of our partners across the hospital, across MGH, across the communities here in Boston to try to make change in this important area. So I really thank you again for kicking off Grand Rounds with a focus on this topic, and I'd be happy to take any questions.
Can we put Peter back on too, if possible? So Shauna, that was great, and I couldn't imagine better, more important kickoff for Surgical Grand Rounds. If Peter's on, do you want to make a comment at all? What a great talk, Peter.
I think
she said she'd do a great job. She absolutely did.
I have really nothing to add. I think Hannah speaks for both of us in that we are here and we are trying to make a difference. And I think we're making a difference in many, many ways. And I invite the audience, the residents, the faculty to join us in this. It's far more than 3 people can do. We're slowly building on a center that is now probably 24 strong and many different aspects of research. So, you know, as a salesperson thinking ahead, anybody in the audience, residents who are thinking about taking time in the lab and are interested in this topic, join us.
Anna, I would just like to ask one question. I know we're almost up against the bottom of the hour. You know, in our M&M conference, we've now added a column where we talk about social determinants of disease. Yep. And I think gun prevention and gun violence prevention really are affected more by social determinants than any other disease we deal with. And the fact that that little tiny dot for the mass shootings is so small, but it gets so much attention. And I think it gets attention when it's in a school or when it's racially motivated or religious motivated. But all the rest of the violence that goes on, which tends to affect young Black males, those communities, even the parts of Boston you point out. I was with my good friend Charlie Yo. There was a shooting in Philly in May or June. I think somebody drove by, shot 3 people in a group. It was really front pages, all the papers and all. And I still follow the roots in Baltimore. I still follow the Baltimore Sun. There's not a weekend in Baltimore. There's not 6 or 7 deaths and 14 or 15 shootings. And that never, ever shows up on the front page, even of the Baltimore Sun, let alone the national news. When will people realize that probably there's no more racially affected disease than gun violence in this country? And when will that become able to, is that the reason why people don't pay attention, I guess is the question. And how can we change that?
Thanks, Dr. Lamo. I mean, I think that this isn't the first issue that people who are most affected by an issue are kept far from the levers of power that have an opportunity to change it. That's really the focus, the mission of our Transforming Narratives initiative is how do we change the stories? How do we take these stories to the media and really develop courses for media to cover these stories in a better, different way? How do we better our violence intervention advocacy programs here? Our program here is as great as it can be. It's really one person. Kate Haskins is amazing, but it's one social worker that's here that is trying to do all of this work of connecting patients who have experienced penetrating trauma with the resources, with the wraparound services to them and their family that would have a chance of using that as a sentinel event that could set people on a different path. How do we expand those resources and really understand what works? But to your point, that is the story that we need to be telling as clinicians. We can't just point to somebody in DC as to fix that problem. We need to use our voices to share with people what we're seeing every day here and among our patients. And I think you're absolutely right. And it's just so interlinked with so many other issues.
This was great. Again, I couldn't imagine a better kickoff for Grand Rounds, except for next week, when Imani and our diversity, inclusion and equity group is going to really touch us with a different topic. So thank you so much for being here, and we look to see you all next week, and all of you on Zoom. There's still plenty of room. We want to see you next week, especially because we have a handful of guests next week that we want to impress with our interest. So thanks so much, Anna.
Thank you so much.